Australia's own inquiry into long COVID has released an issues paper after 2 months of public hearings. It highlights emerging themes, including lack of clear and consistent guidelines on what long COVID is. Joining me now for more on this is the House Health Committee Chair and also a doctor, Mike Freelander. Thank you for your time. So definition was part of the problem according to this inquiry so far. How do you define long COVID?
Well, I think we've accepted that the best definition is the WHO definition of symptoms lasting more than 3 months from initial infection, including things like lethargy, the so-called brain fog, myalgia, muscle aches and pains, sometimes other symptoms, nausea, sleeplessness, anxiety, hyper-vigilance. So we've accepted that the WHO definition is probably the best one. And within that definition, there are a number of different syndromes. We've identified 3 main syndromes. That's the sort of post-COVID complications, things like kidney problems, some forms of heart disease, occasionally stroke, and clotting abnormalities. And then there's the people who have the classic sort of post-viral brain fog, tiredness, lethargy, difficulty maintaining daily activity. And then there's a third group that have really essentially psychiatric symptoms, in particular quite severe anxiety, limiting anxiety, the hyper-vigilance people have spoken about, constantly worrying about multiple different small things, and sometimes depression and, once again, inability to interact with other people.
They're interesting groups when you split them up like that. So group 1, the most severe, and it's pretty clear when you're dealing with that group, if you're talking about clotting and so on, or even stroke, that that's pretty easy or easier to diagnose. So the other 2 groups, the second one's interesting. I guess it's all very patient-driven, isn't it? So when we have rates of long COVID, and there are lots of numbers point out there, oh, maybe there'll be 500,000 people. Is it a bit hard to sort of say that with much clarity? People could be feeling lethargic for a whole host of reasons, because basically half the country's going to get COVID. Suddenly we might get a very inflated number of long COVID.
Now, look, you're exactly right. I mean, it is difficult to define the numbers because we have no national database, and I think there's a great need for that. We also have rates in Australia that probably aren't as high as being reported overseas. It does seem that the Omicron variant, which is what most Australians have had, is a little bit less likely to cause long COVID. So our numbers are probably not as high as reported overseas, where numbers as high as 10 or 12% have been reported of people who have infections ending up with long COVID. We're sort of more 5% or less. And also, we have a very high immunisation rate that seems to have had some protective value against long COVID. So our numbers probably aren't as high as reported overseas, but certainly very large numbers of people. And of course, the vast majority of those people aren't going to need to be managed in hospital. They are going to be managed in primary care, and it's very important we support.
And then cohort number 3 is an interesting one too, because on the one hand, we've got governments wanting to limit spread, not overwhelm hospital systems in particular, and make people aware who are particularly vulnerable to COVID around when there are waves coming. But is cohort 3 growing because people are scared, people are anxious, and more anxious they were before COVID, and in some cases where they're not particularly vulnerable, maybe overly anxious? Is there a role politicians, the media have in sort of making sure cohort 3 doesn't grow unnecessarily?
Oh, look, definitely. I think it's very important that with our report in particular, that we report on the evidence base. There's a lot of anecdotal reports, but I think we have to be very evidence-based and evidence-focused. And as I said, getting the data about this is very important, but also reassuring people. It does appear that the vast majority of people who do get long COVID do in fact get better. And one of the tasks of our inquiry is to see how can we help people, number one, get access to information, number two, get access to supports, and number three, understand that they will almost certainly get better within a reasonable period of time. So, our inquiry needs to be evidence-based, and we need to make sure people understand that there will be supports available and that they will get better.
Just finally and briefly, how do you think GPs should be dealing with this? I guess there's always going to be people that try it on. I'm not saying long COVID's not happening, but they'll go to their GP. I've had COVID, write me a sick certificate for a few weeks in a row. I mean, you can't say someone's not feeling lethargic or nauseous or have brain fog. How does that get handled so it's a reasonable use of the health system and also that the economy doesn't suffer as well?
Yeah, well, that's exactly right. It is going to have effects on our economy and on our schools and universities as well. I think GPs are pretty experienced at dealing with these sort of issues, and they're pretty good at sorting out who has real ongoing problems and who doesn't. We need to support them, and this is where some funding will be needed and perhaps different models of care. We have availability of things like telehealth and digital health apps. There's some very good supports that are being used overseas, particularly in Great Britain. And we need to investigate those possibilities and supports as well. But I have confidence in our GPs. I think they do a great job, and I think we will be relying on them to help us get through this.
Mike Freelander, appreciate your time today. Thank you.
Great to talk to you. Thanks a lot.